Welcome to PemChat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome back to the PemChat podcast. Today, we are going to be talking about the management of fever in otherwise healthy kids that are 3 to 36 months of age. And this is a really common chief complaint that we see every single day in the ER. I bet if we logged in right now, Andrea, half the people on the board would be there for fever.
Minimum.
And this is the bread and butter of what we do. So before I worked in this population, I did a lot of flu, strep, and COVID testing. And I really didn't have a systematic approach to these visits. And like many of us, I realized later after I transitioned to children's that my approach could have been a little bit more evidence-based.
Same.
So we are hard on ourselves in medicine, that's for sure, but we are definitely teachable. And that is really the why behind this podcast and why I make this podcast for everybody. So joining me today is one of my favorite people in the whole world, Andrea Perkins. She is a physician's assistant or physician's associate. What are you now?
Physician associate.
Physician associate. Andrea is incredibly knowledgeable, and she comes with a wealth of experience in both pediatrics and community-based EDs. We have a hard time working together because we like to talk too much. So no better place than for us to do it here on the podcast. So welcome to PenChat, Andrea.
Yes,
thank you for being here.
Thanks for having me.
So before we dive into fever, share with us something about yourself, maybe that I don't even know about you.
Oh, my favorite little tidbit that surprises people is that during COVID, I briefly worked as a COVID compliance officer for an HBO show. So it was my job. It was my job to coordinate testing for the actors, actually, so that they could come back online to recording in a safe way now that COVID was in play. So,
Wow,
yeah.
that is interesting.
Yeah.
That's really cool. Okay. Do you want to tell us where you've worked?
Sure. Yeah. So I'm entering my 11th year of practice. The first half of my practice was just in community emergency rooms. So I saw adults and children. And as we touched on a minute ago, I felt like I knew what I was doing. And then recently, the second half of my practice has predominantly been with children and children's emergency here in town. And yeah, there's a lot of things that we were doing that weren't necessarily evidence-based or algorithmic, which I feel like we have now, which is much more beneficial to the patients and the providers. And so I have the same experience that you were touching on, where what I had been doing wasn't necessarily the right or most correct way to do it. So I really appreciate this and wish I had had this resource when we were getting started. Yeah.
And we don't know what we don't know, right?
Yeah.
But we can learn. All right. So let's start talking about fever. This is super basic, but what is fever? Let's define fever because we hear all kinds of crazy numbers out there.
We do.
What's a fever?
That's true. So normal temperature is 98.6 degrees Fahrenheit, whereas fever is greater than 100.4 degrees Fahrenheit, and that is taken rectally. We have a lot of parents coming in with their thermal scanners that say one thing and their TM thermometer saying something else. I like to tell parents this is a screener, the scanners, and if it says it's febrile, let's go ahead and go back to a rectal temperature, or if they're old enough to follow good directions, an oral temperature. But yeah, greater than 100.4 degrees Fahrenheit.
Yeah. And talk to me a little bit about the patho of why fever happens.
Yes. So whenever you get an illness, whether that's bacterial, viral, whatever, our body has a thermostat in it, which we're familiar with, the hypothalamus, and it's good at regulating how high a temperature goes in general. Whenever we receive an illness, it starts an inflammatory and immune response that creates a cascade predominantly with prostaglandins that circulate through the body, make its way up to the hypothalamus, which kind of signals to the hypothalamus that we need to change the set temperature. So we know that at certain temperatures, our immune system does a really good job at burning off some of these minor illnesses. And so it's a way of a permissive temperature that is your body is allowing to fight the illness quicker and more efficiently. So the hypothalamus on its own, even if we don't treat the fever at all, usually stops the fever at 104 to 105. And at that point, we can use dilation or constriction of extremity vessels to lower the temperature in a safe way. We'll also have sweating, chills, things like this to cool off as well. But essentially, the immune response inflammatory cascade that creates a signal in the hypothalamus to raise up the temperature in a safe way.
Yeah. The take home here is that like the body is causing this to happen.
Correct.
And so this is not a bad thing. And I think it's just scary to parents and some providers. They're afraid of fever. And we have a lot of fever fear in communities. But really, this is the body doing this in response to illness. And this is not a bad thing, right? The fever is actually providing a benefit,
Yeah,
which is
exactly.
fighting off the illness.
Mhm.
So, talk to us a little bit about how this differs from hyperthermia, babies in a car, or it's hot
Right.
outside, or like external sources of heat.
Right. So the same as in our own home. If it's summertime, it's really hot, it's 105 degrees outside, and you really would love to set your temperature at 68 degrees Fahrenheit like me. It isn't going to work, right? We're going to do all that we can to try to cool it off, try it, cool it off, try it, cool it off. But if there is an uncontrolled response from external forces, such as heat, being trapped in a car, things like that, no matter what we do, your body can't keep up to cool you off fast enough. Whereas a fever, is an internal response in a controlled environment to allow your immune system to do what it needs to do. To It's essentially giving it free rein. You're allowed to do this, whatever in these parameters to get rid of this virus. You're allowed to do what you need to do up into a point. Whereas
Mhm.
hyperthermia, that is not what is going on. You have an external heat source that your body can't keep up with, and so that is where damage to the brain. That is where end organ damage in general can occur.
So the literature talks about, quote, a fever of concern. And this is back in literature with regard to like management of fever in kids. What does that mean when we talk about 102.2 and that's the number that they quote? What does that mean? And do we need to be worried about this number?
So typically, we don't worry about a number specifically. It's what the patient looks like. Are they feeding well? Are they alert, oriented during the fever, right? There isn't a specific number that everyone should panic about. But in ages 3 to 36 months, again, we talked about febrile neonates last time, so we're not focusing on that group today. But in the age 3 to 36 months, that fever of 102.2 is where it's a higher risk of things being more significant. So that, depending on the child, depending on their vaccination status, depending on male, female, whether they're high risk for UTI, that's when we start to consider other options. Like, could this be something that might require an antibiotic? Could this be something that might require more intervention than just a virus where we wait it out?
So, when we start talking about these algorithms, and we're fortunate to have an algorithmic approach to this now, there's a lot of reference to fever having a source or not having a
Mhm,
source. So, I thought it'd be best if we just kind of talk about what that means first. So, what does it mean if you look at a kid and you have a fever and you find a source?
mhm. So it means that there's a lower risk of there being a negative outcome or a more serious cause of the illness. If we know on exam, I see a pneumonia I've identified. I know this child has flu because it was positive on the testing. I know that they have joint pain, osteomyelitis. I can find it on exam, then it's actually less likely that they have something else causing it.
So we are seeing a kid in the ED with a fever without a
Mhm.
source. What are we thinking of beyond that? What needs to be in our brain and our differential when we're talking about this population?
So the biggest question, I think the biggest difference in how we manage these children is, are they vaccinated? And so a fully vaccinated child has to have received their vaccines up to 6 months. So once we reach the 6 month point and move forward, you start to look at these kids in a different way. I'm less likely to find a kid that's septic. I'm less likely to find a kid that's developed meningitis from these things. Kids younger than 6 months of age are either incompletely vaccinated because of the age or unvaccinated in general. Then you're going to be doing more of a workup for these kids. So we're going to be looking for signs of the more ominous diagnoses. And so we do things like blood work, check inflammatory markers, check a urine, check a chest x ray, things like that in these kids.
If you're not familiar with what it is in the vaccine schedule that we're talking about that makes you sort of fully vaccinated, explain to the audience why we are very, very curious about whether or not you got the 2, 4, 6 month vaccines, why they're important.
Right. So the Prevnar, the Hib, these can lead to pneumonia. These can lead to the more ominous illnesses that we've alluded to. And ultimately, your risk of bacteremia and a negative outcome are cut significantly when we receive these vaccines. And so once we reach 6 months of age and have had them, we have a sigh of relief that we know that we don't have to worry quite as much about these negative outcomes.
Yeah, your risk goes from 13% to 1, so
Hmm.
pretty incredible, and some sources say you can actually get there with 2 rounds of these vaccines, so 2 4 months,
Right.
others say 3, but this is really when you're asking somebody about their vaccination status, it's very important to be very clear about what they have gotten in these first rounds of vaccines, and did they actually get their 2, 4, 6 month vaccines?
Right.
Because we really feel so much better about these kids. They go in a totally different category. And as you're going to see when we talk about the algorithms, we work them up totally different. So, super important that you're asking people in this age group about their vaccination status. We already talked about what it means to be vaccinated or fully vaccinated.
Hmm.
I think, did we touch on what like under vaccinated or under vaccinated by age means?
I don't think specifically, but 6 months and up, they've received all of them to that point. But we would focus more on if you're less than 6 months old, then you are under vaccinated by definition. You haven't been
Hmm.
able to get the vaccines that you need, right?
Yeah.
If you are, so a lot of parents come in with this delayed vaccine schedule, or they'll come in with certain things they're kind of questionable about. They want to break it into components. I only want to do this part. I only want to do this part. And so that when we see that, it helps us determine if they're under vaccinated or not, and then we can approach the algorithm accordingly. So if you're fully vaccinated up to 6 months and beyond, then things get a lot easier for us. If you are less than 6 months, by definition, under vaccinated, or if you've missed the important ones along the way, then that would be classified as under vaccinated.
Okay, so let's talk about an exam for one of these kids. And it might seem really basic, but I feel like these are pearls I learned when I came to children's. Walk me through what a physical exam looks like and what you're looking for.
Right. So at a children's facility, we're taught in general, just for screening for child abuse and other things, that every child under age 2 is undressed. And so I feel like it's rare for us to miss skin changes, which is things you would see in Kawasaki's, things you would see with cellulitis, things you may see with an abscess. And parents aren't necessarily bathing the child every single day, especially if they're sick. They're doing what they need to do, right? So they're going to miss these things. So make sure you're checking the skin first. To look at the vitals, see if it's directing you one direction. Ask the parents more specific questions to see, are they pulling at the ear? Are they feeding less? Or do they feel like they cry more when they're feeding? Could that be indicative of ear pain while they're sucking? Take a look in the ear, focus especially on the mastoid too. I feel like mastoiditis is missed pretty frequently before they get to us because we're used to seeing these secondary things
Hmm.
in a child with an underdeveloped immune system. These things happen. In an older kid that has developed sinuses, you can check sinusitis, make sure to position their head so you're not missing it. A big one I feel like we miss pretty or that is missed pretty frequently in outlying facilities too is a joint exam. So a kid with osteomyelitis is going to look like any other kid if you don't move their joints. So
Hmm.
have them stand up, walk them, have them point their toes, have them flex, have them push against you and see if you can find anything that maybe was missed first.
Yeah. Good lung exam,
Mhm.
heart exam, right? We talked
Exactly.
in the chest pain podcast about persistent tachycardia being concerning.
Mhm.
So, yeah, a really good physical exam is important. And sometimes I'll talk to parents about this too. They get frustrated going to the pediatrician's office because they're like, it's a virus, it's a virus,
Yeah,
it's a
yeah.
virus. And I'm like, well, the reason we make that conclusion is because we've done this really good physical exam.
Right.
And I'm looking for these specific things. And if I don't find them, that's good. And I can kind of rely on it's a virus. Okay. So Up to Date has a lovely algorithm for both the immunized and unimmunized child with regard to working up fever. Obviously, that's behind a paywall. I'll put the link in the show notes, but Andrea has changed it to make it her own and combined it. So we'll definitely post a link to her algorithm. But let's walk through the algorithm together. Let's start with our immunized group. So these are kids that are actually 6 to 36 months fully immunized. How we're going to work it up.
Mhm. So well appearing, temperature greater than 100.2 degrees Fahrenheit without an identified source. So these kids that are fully vaccinated, the main at greater than 6 months, the main question is, do I need to do a urine on this kid? And so the algorithm helps us determine whether we do. So the first question is, how long has the fever been? So a fever for greater than 5 days always gets an additional workup because of the risk of Kawasaki, so we could talk about that later. But a child with a fever for less than 5 days, we look at the urinary risk. So there's all these things that go into it to help us determine whether they're high risk or not, whether they're female, whether they're an uncircumcised or circumcised male, less than 6 months. And so to simplify that, there's a resource that we use called UTI Calc. Um, I think the website is uticalc.com. It's very
It is.
self-explanatory, but you can
Yeah.
plug it all in there and it will help you risk stratify these kids. And so females less than 2, uncircumcised males less than 6 months, et cetera, and help you go through there. So we get urine on these kids. Obviously, if they're not well appearing, then we're going to do more of a workup on these kids in general. But that's when we would consider chest x-rays and blood work, all the other things.
Can I tell you how many times I called Kaylee and said, "Do I need to get a urine on this kid?" And she said, "Go to
UTI Calc.
uticalc.com." And yeah, on the 15th time, I was like, maybe I'll just go to
Yes.
uticalc.com. Yeah, so great, awesome tool. It tells you who needs a urine and who doesn't. And so you don't have to remember all this stuff. They do list it on the algorithm, but it really helps you navigate that. And then once you have a feel for who's at risk and who's not, you don't necessarily have to use the tool, but it really helps you if it's not something you do on a daily basis. So yeah, we decide, do they need a urine? Do they not? And that's because we would need to give them an antibiotic and not just assume that this is a viral illness, right?
Correct.
And so it really guides you on their care. It walks you through who gets an antibiotic, who doesn't. And then it also talks to you about whether or not they're going to be discharged or admitted to the hospital.
Hmm.
And that's really based on all the normal stuff we talk about, right?
Hmm.
Do they look good? Are they drinking? Can they, no social problems, things like that.
Right.
So really simple. It's a simple algorithm. And I think that's what the part I was missing before is like understanding their risk for UTI. Like, I'm not sure I really thought about that a lot before I was working in pediatrics. Like, that should be on the forefront. And when we get students, I know you do this too, Andrea, when they come back and they're presenting, I'm like, have they ever had a UTI
Oh,
before?
no. The first couple of days, they go in
Yeah.
and out, and I say, "I don't even wanna hear from you if you don't have that answer. Are they circumcised? Are they vaccinated 100%?" Or,
Have you had
"Yeah,
a
have you?"
UTI? Yeah,
"Yeah,
yeah,
go." Like,
yeah. I think we drive everybody crazy because we're like, ask every single patient.
everyone. I don't care if it's an ear infection.
That's right. I still want to know if they've had a UTI in the past because just goes to risk stratification.
Mhm,
Okay, so I have made some quick cases to just run by you, and I'm just going to give you the chief complaint, and I want to hear from you. And this is assuming they look well, and we know that they're fully vaccinated. So, what would you do for this patient?
mhm.
All right, 9-month-old female comes in with 3 days of fever and congestion, no obvious source.
Mhm. So, automatically, we know that she gets a urine because she is a female, and females are higher risk in general at that age. So, we're gonna run the algorithm. We're gonna look at the fever. Has it been greater than 5 days? No, it hasn't. So then we know she's fully vaccinated, so we get into the safe area or the safe part of the algorithm. So, with less than 5 days of fever, we're just gonna go straight for a catheterized urine on this kid. Mhm,
Perfect. 18-month-old male presents with 2 days of fever.
mhm.
You see an ear infection.
Mhm. Then he has an ear infection.
Great.
So, if he were less than 6 months old and uncircumcised, that could change things, but once we get beyond this point, if you put him in, we would run the algorithm, so it's less than 5 days of fever, so we don't need to worry about blood work. We know he's fully vaccinated. Circumcised versus uncircumcised matters less once we get to a certain age, that you can also put in UTI calculator if you can't remember, but yeah, he has an
Yeah.
identified source. We don't need to do anything else.
Same patient, but now it's a girl, 18-month-old female, 2 days of fever, has an ear infection.
So that's when we're in the tricky part where you're a female, so you get a urine anyway. When it comes to this, when I have an identified source, I always tell the parents, like, she is still risk for a UTI. This is still something that we're going to need to investigate, but it is a catheterized urine at this age, and so at that point, it tends to be more of a parental feeling about it. You can put her in UTI Calc and see what her percentage is, but it's probably going to be higher.
Okay. So now we have a 2.5-year-old female,
Mhm,
fever and vomiting.
mhm. So We have fever and vomiting. That could be viral gastro, which is what most people would think. It could also be urinary tract infection. So we run the algorithm. The fever isn't longer than 5 days, less than 5 days, which means the number one thing we're wondering about is a UTI. So we would talk to the parents and ask if there's a history. If there is a history, then we could check it at that time. But she has higher risk because she's a female. So how old was she? 36?
30 months, 2.5.
Yeah, yeah. So it's still warranted to check a urine at that age.
Yeah, and some people say girls can present with just vomiting and
100%.
have a UTI.
100%.
Yeah,
Yeah.
so we're always more suspicious in females. So this is 30-month-old male, 2.5-year-old male, fever, vomiting. We haven't done anything. What's your initial
Yeah.
approach?
So how long's the fever been going on? Less than 5.
2 days.
Yeah, less than 5 days. So we're not going to do any sort of blood work for him. I assume he's fully vaccinated. So, yeah, probably give him some Zofran. High five.
Love it. Love it. Okay, let's move into our group of unvaccinated or undervaccinated by
Mhm.
age, meaning they're not old enough to get their 2, 4, 6-month
Right.
vaccines. This algorithm looks totally different. There's more to do. Before we talk about the algorithm itself, let's talk a little bit about where the world is today.
Mm.
More and more families coming in with unvaccinated children, or like you mentioned earlier, the delayed vaccine schedule. How do you approach this with parents when you explain it to them? Why we have to do more for this kid? How would you tell a parent that?
Right. So I feel that every child that comes in that's unvaccinated or has a family that is concerned about vaccination, I don't want to miss the opportunity to educate with the understanding that they don't have a relationship with me. They're not going to trust me as much as their primary care provider. But in case there was a missed opportunity, I want to always send them home with education on what we're doing and why. And so that's at the end. At the beginning, I tell them, you care about your child. I know that because you brought them here. We care about your child. And because of that, we don't want to ignore some of the rarer causes that are vaccine preventable. And so we respect your decision with your child. But if you bring them here, you put your trust in us to do the right thing for them. And so we always, every single time that they come in, if they're unvaccinated, we're going to have to do more of a workup for this kid to be sure that we're not missing something dangerous.
Okay, great. How do we run through this algorithm?
So for an unvaccinated kid in general, up to 36 months, or for children less than 6 months old, being considered under vaccinated, then they're going to get pretty much a full workup every time they come in if there's not an identified source. So these kids are going to get blood work with a CBC, inflammatory markers, which are procalcitonin and a CRP. We're going to get a blood culture that, depending on the age, you may send it right away. You may hold it and send it if the procal's elevated. You, can do viral testing on these kids if you're concerned and didn't catch something right away. We can do, a urinalysis on these kids and also a chest X-ray. So the key to these kids is ruling out the more ominous sources of fever because they are under vaccinated. And so these are the kids that would benefit more from a respiratory viral panel, like a bigger panel to try to catch some of the dangerous stuff like pertussis and all those.
Okay. Let's talk a little bit about when you get the labs back and their white count is greater than 20,000. What should that trigger us to think about?
To think of a secondary source that a bacterial source. So we're going to be looking more closely in a urine on a kid like that or a chest X-ray, because typically
Yeah.
that's beyond a normal inflammatory response that we would see with a viral illness. And every now and then we'll see something else like adenovirus, influenza. They love to do really big reactions, but by and large, with an elevated white count that significantly, we're going to be paying close attention to a procalcitonin on those kids too to help us determine if it's likely a bacterial or a viral source.
So we get our labs back on this kid. We had a white count greater than 20,000. So we added the chest x-ray. Let's say our inflammatory markers are elevated. What are we doing next?
So at this point, we'll send blood cultures and start on an empiric antibiotic with close follow up. If the child is ill appearing or has decompensated while they're in the emergency department with us, then we would admit these kids. Or if they don't have safe follow up or reliable caregivers, then of course we can always admit those kids for for close observation. But if they've got reliable follow up, very attentive parents, then we'll send them on an empiric antibiotic and have them follow up closely.
Okay, great. All right, let's do a few rapid fire cases on these unvaccinated
Okay.
children. All right, so 9-month-old female comes in with a 3-day history of fever and congestion, no source,
Mhm.
unvaccinated.
So 9-month-old unvaccinated, is going to look the same as the younger babies, so we're gonna do all the things. We're gonna do inflammatory markers, procal, CRP, we're gonna do a CBC, we're gonna draw and hold a blood culture, do a urine, and do more extensive viral testing in these kids, which is looks more like a respiratory viral panel, or, if they have vomiting, whatever, you might do a GI pathogen panel to try to identify the source. If at that point, the inflammatory markers come back elevated or something looks concerning, you can add on a chest x ray at that point and see if we're missing maybe a occult pneumonia.
So 18-month-old male, 2-day history of fever, bilateral ear infection.
Mhm. So, with an identified source, because again, that's the distinguisher here 3 to 36 months, fever greater than 102.2 degrees Fahrenheit with an identified source, such as otitis media, nothing more is needed unless there's something else the parents tell you that's concerning that you've missed.
Okay, so you can put them on antibiotics, just have them follow up with their PCP.
Correct.
Okay. Same patient. Now it's a girl, 18-month-old female, 2 days of history, has an ear infection on exam.
So, with the identified finding again, that is likely the only cause, but because of her risk of urinary tract infection because of the age, then, you can put it in UTI calc, but you're gonna be checking
Yeah.
that urine, or at least
Yeah.
suggesting it to the parents.
30-month-old or 2.5-year-old female with fever times 1 day and a barky cough, unvaccinated.
So, this is a hard one because to identify a viral source, you have to run it through a test that is then positive. So if she's COVID, you could do, abbreviated testing. But if she has a barky cough, the assumption is that it's parainfluenza virus. If it's parainfluenza virus, give her Decadron and let her go. But in an unvaccinated child, the question could also be, is it pertussis? And so a respiratory viral panel would be more helpful to distinguish if it's paraflu or if it's pertussis, and that would determine what we do next.
Yeah, and you can have croup from any virus, right? We see a
Yes,
lot right,
yes.
right now, tons of croup with flu.
Mhm.
And so they might qualify for Tamiflu. They might be in a high risk group and need Tamiflu. So certainly something to
Right. So I
consider.
think that's an important distinction too, is a lot of the time we're busy in the ER. Kids are waiting for a long time before they're seen. And so we do a kind of scan down who's in the waiting room and do some preliminary testing before they get to us to try to save them and us time. If it's an unvaccinated child or a very young infant, I'm more likely to do a respiratory viral panel on those kids for complaints. Whereas a fully vaccinated child, I'm more likely to just do a flu, COVID, RSV and be done
Mhm.
with it.
All right. Last one, 2-year-old male, 2 days fever, vomiting. He's unvaccinated.
So step one is identify source. Is there a source on exam? If
No source.
and if you don't see a source, then we're within the 6 to 36 month unvaccinated, so we're going to do a more significant workup. You're gonna do your blood work, inflammatory markers, hold a blood culture, see what the inflammatory markers say. If they're elevated, we could do a chest X-ray at that point. And you may do viral testing depending on what the kid looks like. If the parents say he's had no symptoms, but he's obviously congested, you may do an RVP, something like that to rule out something else.
Okay. When families come in and they say their baby has had fever for 6 days, 12 days, I've had a mom say that her baby had a fever for 30 days.
Wow.
Talk to me about the approach. I feel like before I worked in children's, I didn't really understand this, but we kind of nailed them down about these days. But talk to me about the approach to these families.
Yes. So step one is to make sure that parents understand what fever is.
Hmm.
Parents love to say, oh, he's had fever for the last 14 days. It's been crazy. And they have a 99-degree temperature. So we want to make sure, A, they understand fever, and B, they're checking it accurately. We want to make sure it's a rectal temperature or at least oral temperature in some of these older kids. And they're not just doing a thermal scanner that says every kid has 107-degree fever. We want to make
Hmm.
sure. So once we get to the 5-day range and beyond, beyond 5 days, we start to be concerned about Kawasaki disease, this systemic vasculitis that can cause ultimately coronary rupture aneurysm. It's very dangerous. And so we want to do more of a workup on these kids to rule it out. Once we get beyond 5 days, closer to the week mark, we're also higher risk for the secondary bacterial infections that could be missed, like pneumonia, urinary tract infection. And that's also when we're more concerned about an oncological process. So, does this kid have a cancer we've maybe missed, especially a 30-day kid? That's pretty concerning.
Mhm.
Or will this kid need to move on and go to be evaluated for an autoimmune illness that we wouldn't diagnose that day, but it's something to be aware of? And so these children get the same workup that you would get if you're completely unvaccinated. So they're going to come in, they're going to get CBC, inflammatory markers, which are CRP and procalcitonin. You're gonna get a urine on these kids, a chest X-ray, the whole 9 yards, try to see what's going on there. I have found just in practice that a lot of kids, especially kids that have just started preschool or kindergarten, love to do a thing where they get one virus, start to get better, and catch the next one. And so it can be helpful to get a respiratory viral panel on these kids too, because mom may say, "We had flu last week and he's not better and he's so much worse." That could mean he has a pneumonia that's developing. It could also mean that kid went back to school and now he has COVID. So just
Yeah.
checking for things like that.
All right. So let's talk about the management of fever. Talk to us just briefly about the dosing for ibuprofen and Tylenol and why we treat fever.
Yes, I tell parents all the time their fever is not dangerous. It doesn't hurt children. It's not harmful. It's the body's normal response to an illness. But that being said, we do treat it. And the reason why is because all of us have been sick before. All of us have had flu. All of us have laid around and didn't feel good. But we are adults and we say, I don't care if I don't feel good. I have to drink. I have to get up and not die of dehydration. Children that have a sore throat lay around and can decompensate to the point that they have to be admitted for a dehydration. So we want to treat the symptoms in these kids to get them feeling good enough for the highest probability of success that they will not have to be admitted because of that. And so treating these symptoms, you can use children's Tylenol, children's ibuprofen. Tylenol, you can do 10 to 15 milligrams per kilogram at virtually any age. Of course, neonates, it's a whole different question. A lot of the times they don't want them to take it unless they're in the ER. So that's something to discuss with their pediatrician.
We discussed it last
Okay,
month.
good. And that can be given every 4 hours. Whereas children's ibuprofen is safe to give older than 6 months old, and this is 5 to 10 milligrams per kilogram dosing. Now, there's some question about how to give it. So a lot of the time it's recommended to because the question is, am I gonna forget when was the 4 hour, when was the 6? So alternated. If we give children's Tylenol, then 3 hours later give ibuprofen, then 3 hours later give Tylenol, then they've got good coverage and they don't have to keep up with what they've done last. But the question then becomes, are we creating a fear in these parents? Oh, you have to
Mhm.
treat the fever. It's so dangerous. And so personally, I feel that if we've counseled the parents about how fever is not dangerous, first off, parents are shocked. They think it is because even local pediatricians, they will say if a fever is greater than whatever, go to the ER because they can't evaluate the child. They can't see how they look. And so,
Right.
right. So, good coverage. Some parents, if they want to just give Tylenol, fine, that's okay. But educate them that in the in between, they may not have 100% resolution of fever. And that is okay because the body is doing what it's supposed to be doing. And so I always tell them, like, oh, good job. Great. You vaccinate your kid. They're safe and their body is responding exactly how it needs to be. That means it's a healthy kid. That's good.
Yeah.
And parents come in all the time so stressed because I feel like my kid has been sick. Constantly, I'm worried. Is their immune system working? I'm really worried something's wrong. And I tell them that allergy specialists, immunologists tell parents that their first year of pre-K, they should expect between 10 and 12 viruses. And if that's the
Mhm.
case, they are sick the entire time. And if you are able to mount a fever and have it resolve and go back to normal behaviors, then that's a great immune system. You're doing exactly what you should. We're treating the
Yeah.
symptoms to make them drink, not to
Right.
help the fever. Yeah.
And I'm sure you tell parents this too, but I'm always like, let's look at the kid and not the number on the
100%.
machine. And when they aren't convinced by that, I'm like, well, if I have you on a monitor and it says you're dead and I'm going to start CPR, but you're talking to me, you would not appreciate that.
Yes.
So, I mean, it's the
Yes.
same concept, right? If your kid is running around the room, eating, drinking, doing all the normal things, looks great, and they have a 104 temperature, I am not concerned about that temperature in
No.
your vaccinated child.
Mhm.
But, if they are laying around and can't drink and look terrible, I don't care if their temperature is 99 or 104. We want to see them. We want to make sure they're okay.
Yeah, exactly.
Yeah. Yeah, a lot of fear out there for sure.
Mhm.
So, and at Children's, we talked about this in the medications podcast. We tend to use that 15 milligrams per kilogram for
Right.
Tylenol and the 10 milligrams per kilogram with ibuprofen. But yeah, stressing to parents that you don't have to have the fever go away and never come back. It's going to come back,
Yeah,
right? Just tell
as
tell
it
them it's going to
does,
come back.
because Tylenol is only 4 hours, you know?
Yeah.
I also find it helpful too. I think as parents, we care about our kids. And when we see them not their normal, typical self, it's very concerning and stressful.
Hmm.
But 9 times out of 10, when this parent has brought in their kid, they're sick with the same thing. And so when they say, "Oh, I'm so worried. She's laid around. She's not herself and she's just not feeling well." And then they give her Tylenol and she's running around having the time of her life. I'm like, do you actively have the flu? Do you want to run a marathon right now? And they're like, no. And I said, okay, but when you get your Tylenol, how do you feel? Like, that's what we're concerned about. Are they able to bounce back? Are they able to behave more normally with the fever reduction? It's not, are they responding appropriately when they have a fever, you know?
Yeah. I never want to run a marathon. So.
Same.
Okay. Well, thank you for being here today. But let's end with kind of a little closer. If you could leave ED providers out there with three pearls and how to treat fever in kids, what would they be?
Mhm. So consider vaccination first. We need to know their vaccination status above all else. Counsel parents on what a fever is, because I found that that helps significantly when they understand that it's a normal response to an illness. I feel like a lot of adult providers, we have fully functioning immune systems. We're adults by the time we're seeing you. And so when they come in with a really high ominous fever, it's a little weird, but kids can have it with anything. And finally, we don't have to be afraid of fever in general. It's we can treat it for comfort, but not for concern.
Yeah.
Yeah.
Have you ever had a parent ask you if they shouldn't treat the fever?
Yes, I have.
And how do you answer that? I'm just curious. I've had a parent ask me this maybe once or twice, so
So
I'm
I
just curious.
always tell them we don't have to treat it at all. It's not required. Your hypothalamus treats it for you. And so your hypothalamus knows better than I do about whether we need to manage it or not, because it's in there, it's in the body assessing what needs to be done. And so it's going to permissively raise the thermostat no matter what. But if you have a kid that can tolerate it and that parent understands that that kid's going to be fine and still drink, absolutely do what you want. You don't have to treat it. It's not going to cause any harm. But if you have a kid like I do at home and she's going to lay around and it's the end of the world, then that girl's going to get some Tylenol. Sometimes we just need it.
Do you think illnesses would resolve faster if you didn't treat fever?
So that was something I was actually discussing last night with a friend. We were talking about it, and maybe, I mean, our body knows what to do to fight these illnesses. And so the more data we get, the more efficient it would become. So I feel if we didn't slow it down, our body knows what to do and it would probably be doing a better job.
Yeah, I think that was the question the dad asked me. Am I creating a problem? Am I making my kids sicker by treating fever? Like, I think we should not treat the fever at all and let this resolve. Whereas my wife wants to give this kid a bunch of medicine and make them feel better.
Right.
But are we prolonging the course of
So,
illness?
that's an interesting thought too, because every medication we give has risk. And so, even though it's low risk and even though it's widely accepted, is it potentially dangerous to be exposing our child to medications that could negatively impact their kidneys and their liver if we give it at the wrong doses or for prolonged periods, right? And so
Hmm.
it's always risk benefit. It's
Yeah.
different per family. Some people will say, it's better to let it ride, and some people absolutely can't stand to see their child suffer even for a second. So it's just kind of
Yeah. And that's the rarity. Most people are like, I'm treating it every 3 hours. I've written them all down
Yep.
and keeps coming back. All right.
Yep.
Well, thank you, Andrea. This was great. Thank you for being here with me today.
Yeah, thanks for having me.
All right.
See you at work.
Thanks, everybody, for joining us here today on PemChat. I look forward to seeing you next month when I have a really special guest, Dr. Margaret Wong, and she's going to be here to talk to us about the return of vaccine-preventable illnesses. It's already happening with a measles outbreak just down the road in South Carolina. This is a good one, guys. Can't wait to see you next month.
Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.